Good morning. I'm Tachi Yamada. I'm a venture partner of Fraser Healthcare Partners. I have also been a longtime faculty member at the University of Michigan and have a strong connection to the Michigan Center for Global Health Equity. I would like to introduce my colleagues on this session. Agnes Binagwaho, who is the Vice Chancellor at the University of Global Health Equity in Rwanda and former Minister of Health of that country. And also by Paul Farmer, who is the Chair of the Department of Global Health Equity, Global Health and Social Medicine at Harvard Medical School and the founder of Partners in Health. We're here today to discuss the COVID-19 pandemic, the implications for Africa, not only from the standpoint of its health and social and economic implications, but also on the challenges associated with equitable distribution of vaccines and medicines for treatment of the illness. Now, by background, I should start by saying that Africa has been spared by relation to the impact of the pandemic on countries in Europe and the United States. We're not certain of why this is the case, but both the incidence per 100,000 population and the mortality per 100,000 population has been much, much lower in the African African continent than elsewhere in the world. But having said that, the problem there is still severe because, of course, there is a paucity of intensive care units or even the availability of oxygen for those people who get the severe illness. Not only is that the case, but it is possible that there is a relatively much higher incidence of the disease in asymptomatic situation because the emergence of mutant strains from Africa indicate that the virus is spreading and dividing quickly. Mutations occur as the infection spreads and the virus divides frequently. The main concern for the world right now is the emergence of a strain in South Africa, which does not seem to be protected by the currently available vaccines, nor by the monoclonal antibodies that are available. So the issue for us in the northern countries is to think about how what happens in Africa affects the whole world and how we address the issue of equity, health equity, the distribution of appropriate tools, preventions, and treatments for the condition. This problem is not a new problem. In fact, in the 2009-2010 H1N1 pandemic, this very same problem arose. At that time, Chris Murray wrote a very important paper in which he modeled the H1N1 pandemic after the 1918 influenza pandemic and predicted that 95% of the deaths that would occur in the world would occur in the 50 poorest countries. Amazingly enough, that has not panned out with this pandemic, but still the threat is there. And we have to address this issue of equity, if not for this pandemic, for every pandemic that happens. You see, the problem is, although vaccines, through a miracle of science and pharmaceutical manufacturing, have been available within 1 year of the sequencing of the first virus strain from Wuhan, They take time to manufacture and to distribute. Despite the very optimistic projections by pharmaceutical manufacturers about how many billions of doses they would manufacture, of course, the reality has been very different. Manufacturing is hard. Manufacturing takes time. It's not just manufacturing the vaccine, but it's actually filling the vials with a vaccine and then distributing them. That is often the biggest challenge. Even in the richest nations in the world, this has been a very difficult problem. You can imagine what the problem might be in poorer nations with less well-developed health systems. Back in 2010, during the height of the H1N1 pandemic, when I was at the Gates Foundation, we developed a set of principles that we tried to propose to the world about what should happen in this kind of circumstance. And they involved a number of key points. And if I could read a few of them. First is that the global community should take steps to protect all populations, including those without resources to protect themselves. That seems self-evident. Vaccines should be considered in the context of comprehensive pandemic preparedness and response efforts in all nations. Third, developed countries and vaccine manufacturers should urgently agree upon a mechanism to ensure access to vaccines by developing countries. Fourth, vaccine manufacturers should identify strategies such as tiered pricing and donations to make pandemic vaccines more acceptable to developing nations. Five, pandemic vaccines allocated to developing nations should become available in the same time frame as vaccines for developed nations. Six, the global community should obtain data to help establish a consensus on the safety and efficacy of the vaccines, and efforts should be made to ensure the fullest use of this and other data for distributing the vaccines. Seven, all countries obtaining pandemic vaccines should ensure that mechanisms are in place to provide the vaccine to their populations, to ensure that this scarce resource is not wasted, and donors should be prepared to provide resources and technical assistance to help countries bolster these mechanisms. And finally, the World Health Organization is uniquely positioned to lead the global response to a pandemic virus and should support governments and industry in their efforts to implement these principles. Sadly, those principles were written 11 years ago. They are still very applicable today, and we have not learned the lessons from the H1N1 pandemic. What we have to do now is to take steps that not only can we address the current issue, but that we can ensure that future pandemics, which are sure to come, will be followed by a set of principles that will ensure equity for the treatment of all people throughout the world, rich or poor. So with that being my opening statement, I will ask my colleague Agnes Binaguajo to introduce herself beyond the very limited introduction I gave about her background, and to give us her view of the current situation and what steps need to be taken. Agnes?
Thank you, Yamada, for first of all this great introduction, and thank you all of you to have me here. For my introduction today will be simple. I am a very annoyed grandma. That's what I am, and consider me as such. Just because what is ongoing, COVID-19 has created an unprecedented health threat on a scale never experienced before, with a global consciousness of everyone everywhere in the world informed about the danger of it, not fully, but informed about it. And it has brought out the best of the humanity, especially at local level, but also the worst, especially at international level. For example, As the nations are raised to distribute the COVID-19 vaccine, we are seeing African countries and other developing countries being left out just because of not only scarcity, it's always this story of scarcity, but of Western nationalism. And even we have seen since the beginning of this pandemic, some rich countries pirating medical supply from other rich country and poor country. We need to revisit the international law for protecting individual and the vulnerable in this world. So it's against an international laws, an ethical consideration, and they did it in total impunity. I want to recall the stealing of respirators bought and paid by Barbados, and also containers stolen on the tarmac of airport with masks that were being paid by Germany, stolen by America. Now, on global scale, we have seen also evidence of great solidarity. The COVAX initiative was very promising to equitably distribute safe an effective vaccine to all countries, regardless the ability to pay, and that at the same time focus on the frontline workers and 20% for all countries before going to the second category of people who are vulnerable, etc. Nationalism takeover. While the initial target of 2 billion doses by 2021 have been met in money, the rollout began recently, but we have seen that we are left out. And there are various challenges, and the most important among them is the lack of cooperation, unwillingness of also diversify site. I'm sure that many factories with those goods that are saving life could have decentralized the production, keeping the intellectual property, we don't care, but at least bringing more vaccine to the world. But no, there is this lack of cooperation. And also countries signing parallel agreements that contradict the COVAX. So if we continue like that, we may see some countries not having access fully to vaccination before 2023. However, we know that if we don't vaccinate the poor and the vulnerable, locally, nationally, and globally, the world will not be safe, because you will see variant coming that will also, the people who are vaccinated now may not be protected against. So either we fight together to be safe, or none of us will remain safe, even those who have access to vaccine. And we should take here the lessons that we all learn also with H1N1. You say that very well, Yamada, but also with HIV, when the medicine were there in the Western world, and Africa got access to that only 6 years later. So I insist on equity for an unique reason. Is the only way the world will really manage to control the pandemic. And in my country, many people say that the outcome of the work of the health sector is a miracle. It is not a miracle. We are still a poor country, but we have managed to achieve what we have achieved just because our work was granted in equity. And if we don't do that, I think that the world will not make it. Don't believe that by being complacent with nationalism, you save the West world. No, 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 no. We will not. We need to be all together. Thank you.
Thank you, Agnes. Paul, perhaps I can ask you for your comment.
Just, I'm an infectious disease physician and an anthropologist by way of introduction. And I'm just going to pick up on something Agnes just said, but first by noting that, basically, Tachi, you went back to a document written 11 years ago and underlined the noble sentiments that we still adhere to and need to move forward, but they have not come to pass. And Agnes has described some very recent developments that suggest, and we've had other discussions privately about this, Tachi, that the current arrangements with COVAX and some of the other mechanisms that are being discussed in real time will not serve to meet the goals that you both have outlined very eloquently. And so if time permits it, I'd like to, not in my introductory statement, but I hope we can get back to some of the specifics of rollout, because there's a lot of magical thinking going on globally. We've been in situations of pandemic before. It's true, we weren't around then, most of us, but there are people like Howard Markel at University of Michigan who have written a lot about the various non-pharmaceutical interventions in the response to the big smallpox pandemic, but also the relative impact of other interventions. And it's going to be the same thing now, but the magical thinking is really around, even if we have enough vaccine doses to far exceed the 20% goal, which is itself ridiculous. We've been in the situation before, we've had enough doses and still, as Agnes pointed out, there were still sporadic eruptions of smallpox, and they happened in these clinical deserts. For example, in 1967, I think 67 and 68, the clinical desert, now known as Sierra Leone, was having still having sporadic outbreaks, even after massive vaccination campaigns. And that's when, by that time, as you well know, both of you, there was a lot more focus on ring vaccination and responding to clusters. And, it just strikes me that even as some of us get our second vaccine, we're still thinking in terms of risk categories, right? As opposed to outbreaks or clusters. Somebody is thinking about outbreaks and clusters, of course, but the discussions that we've been having about global rollout and about national and state level and district level rollouts have largely been really just about that question of who goes first. And that's just a very truncated and narrow view of the ethical concerns that we all have. The way that you and Agnes brought it up, those are the real ethical concerns, which are about global inequality, endless delays for those last in line. And when Agnes brought up 6 years between the development of effective suppressive antiretroviral therapy and any kind of meaningful distribution on the continent of Africa, that was a record for rapidity. That was a record for moving fast, 6 years. And for smallpox, you just do the math between 1796 and 1977. And, we just don't have that kind of time. So I do hope we'll have a chance to think a little bit about the technical aspects of the rollout. When should ring vaccination be used? When should we plod forward with our current schedules? And how are we going to address these major structural barriers that will prevent us from meeting these goals on the continent of Africa? Thanks. Back to you.
Yeah, thank you both for these wonderful and perceptive comments. I do have one follow-up on the issue of HIV and antiretroviral therapy. Agnes is absolutely correct that it took years before available treatment became available to people in sub-Saharan Africa and other nations in the world. And of course, one of the great achievements of modern times is the global response to this challenge, including participation by Clinton Health Access Initiative, CHI, and others to lower that pricing, to shame the pharmaceutical industry in a sense, to get Indian manufacturers to make it was made available because of a combination of reduced pricing and generous contributions to the Global Fund, and in conjunction with PEPFAR, that allowed the broad distribution of a treatment. In this case, vaccines actually cost a fraction of what medicines for HIV cost. And yet, although the RNA vaccines are expensive and people will put a price on them, cost of goods as being in the hundreds of dollars, actually it's much lower than that when you consider the incremental price of the first dose after 1 million. Because if you count the cost of capital and the cost of R&D, and you get paid handsomely for it from developed nations, the additional doses are actually quite inexpensive and can be distributed inexpensively in the rest of the world. I don't know why this doesn't happen, and why the charge to COVAX for the vaccines that the manufacturers are currently asking COVAX to pay is as high as it is. And so even $2 billion doesn't ensure the kind of wide distribution of the vaccine that the world needs. What do you think should happen to change this situation? Is this a situation you think that we can shame the industry into behaving properly? Or is this a situation in which we just need to raise more money?
Yamada, I'm going to say something that is even worse. All those developments have been done with the money, the taxes, meaning the money of the people. So that means it's greed. It's only greed and the worst part of humanity. The people want to make money on suffering. First of all, they use your money, your tax, to develop something that they may pay you the high cost. So it's a lack of accountability, and this should stop. How many money of taxes of good people around the world have gone to the development of those things? And I think even again in the US, where you see the same minorities in more position to be infected, in more condition to die because no access to services, and in more condition to don't have access or to be the last to be served for the vaccine that they contribute to build. So law, accountabilities, ethics. And if we let the world to be led by greed, we should not be surprised.
I just was wondering, in terms of the shaming question, it's not clear right now that it's really the pharma big pharma is the architect of this rather shocking vaccine nationalism. We are in the middle of this very cloistered amphitheater of vaccine nationalism. And you asked, Chachi, what could be done right now? Well, if I were the president of Rwanda, I would understand that I'm not the architect of the rules of the game, and I would do what other heads of state are doing, which is try to get vaccine for my people, because that's their social contract to do that. Now, one hopes that that this hypothetical leader of a hypothetical nation would also be concerned about global equity. In the case of Rwanda, that's very much the concern. But given that this is just such a fast moving catastrophe and that every delay in distribution means more deaths, I mean, it's hard to know what the alternatives are given the global architecture that we have. It's going to be nation state, and it's going to be using administrative and political boundaries to make a lot of decisions about a global transnational pandemic. So we're stuck with that, I fear. And one of the things that we need to do in the next few months is really improve the technical quality of the rollout and make sure that all of us are pushing hard to make sure that the barrier really is logistic and not cost, and being last in line in the usual long, sorry list. Because if it is just logistics, there are going to be places like Rwanda that can do a superb job at rolling out even a Pfizer vaccine or something that requires a new kind of cold chain. Because although the default so far in discussing Africa's COVID situation has been often this, oh, you know, they couldn't have done anything right. They must have some natural protection, or it's the age structure of the population, or there's no obesity. Those, you know, hypotheses haven't really panned out so much, not as single hypotheses. So we also need to look for good performance on the continent so that we can learn lessons for North America and Europe. Contact tracing in Rwanda is much stronger than it is in the United States. And why is that? How did they do that?
You know, I've heard, of course, we're quite aware of the infrastructure available in even the poorest nations in Africa for vaccination of children. And you know, the measles is a very good example of that infrastructure having a dramatic effect on death from measles in the sub-Saharan Africa. But the question I pose is whether that same infrastructure for vaccinating children is sufficient or going to provide an advantage for vaccinating a large population beyond children. And that's, you know, I don't know the answer to this, but I wonder, and people wonder whether, in fact, that infrastructure is there. Any comment?
Tashi, let me tell you, Tashi, can I tell you that? Give me the Pfizer, you know, this very strange thing that if you put your finger in the box, you may lose your finger. It's so cold. Give me it. I will make the country vaccinated in 1 month. So don't question, trust. And you see, where are the best children vaccinated on Earth is not in the countries who have the old infrastructure, the cold chain and electricity everywhere. It's where I'm sitting now. Just come and see the data. Just because we design program according context. Of course, we are not going to use the traditional way to distribute vaccine. We are going to create a new way to distribute that vaccine because it's not for kids, it's first for people that are working in the health sector, that are frontline, so they are not where the kids are. So we design a new logistic for the new needs, and we are intelligent enough to do that quite well. So trust, and we can do that. Also,
with all due respect, Agnes, Rwanda is a very special country in Africa.
No, I'm Black, I'm a woman. My DNA is the DNA of all the Black women of my age in Africa.
Okay.
I'm just very vocal. That's the only difference.
Do you think that the same infrastructure exists in DRG, for example?
No, but they can build that if we give the opportunity to the people to do that. And it's not only the health sector. You know why the health sector in this country is good? It's just because the health sector is protected by other sectors. It's a multi-sectorial approach. In RDC, all the people who give 1 million to support health give 2 million to sell arms. So there is unrest. So you cannot build your health sector. It's a multi-sectorial approach, and don't look at the Minister of Health in that country alone. Look to the whole global situation. That's why today I'm very annoyed, even if I'm so happy to see you, my friend.
Well, you know, if I could add something, and I didn't say this at the outset, but I'll mention it now. I've been lucky enough to work with Dr. Agnes for 20 years. And through all of her roles as director of national,
it's very strange.
It is strange. I've been stalking you now for 25 years. And I just wanted to go right to your question, Tachi, which is again a technical one that we need to be asking. Will putting in place let's say, a new cold chain or meeting new cold chain requirements weaken or strengthen the vaccine program. You know, I think we have a lot of data on this now. We have data about the naysayers of scarcity saying, no, if you do this, it will weaken that. If you acquire HPV vaccine, Dr. Binagwahu, as Minister of Health, you'll weaken the other vaccination programs. Paul, if you buy a oral cholera vaccine in the middle of the world's largest cholera outbreak, you may weaken attention to water and sanitation. Now, notice the entirely fact-free manner in which such assertions can be made, right? There actually isn't a lot of evidence that using one vaccine weakens efforts in a general essential vaccination program. But we were able, because we were forced to generate data that showed, in fact, that adding a new vaccine could really strengthen the essential program of immunization in Haiti, Rwanda. And so eventually there has to be a point where we say, why is it that these arguments that we're making, that you can in fact strengthen health systems by doing vertical programs, they could be AIDS programs, they could be women's health, they could be family planning, they could be all of these other traditional vertical programs, we can actually use them to strengthen the entire healthcare system. Now, I do believe Rwanda is exceptional, but Tachi, when you and I were first there in 2005, that nobody was saying, hey, Rwanda is exceptional for its healthcare system. You know, so you got to see that being built. And I just want to say again, you know, the design of the program, taking into account the context, might not overcome war and conflict in the DRC, but when it was applied in Rwanda and lots of other places, we see rapid and positive gains. And I think, again, if we're forced to muster the data to show that introducing a new vaccine, a new cold chain, can still strengthen the EPI, I think we should do it again. But it's vexing because we need these vaccines. We need good vaccines, especially with the emergence, as you said, of these new variants. No wonder people in Rwanda are saying, well, I wouldn't mind having the Pfizer vaccine or the Moderna vaccine if it's more protective. We don't know that yet, but I'm saying, of course, they're going to say that. Thank you. Sorry if I went on.
You know, Paul, you and I were part of a global commission to sort of explore how we prepare for the next pandemic. This was about 6 years ago, 7 years ago. And one of the suggestions that came out of it, I thought was very, very good and is relevant to this pandemic. What, for many countries in sub-Saharan Africa, as Agnes pointed out, the imperative to spend on national defense is a really important imperative. And the two most powerful ministers in any cabinet in these nations is usually the Minister of Defense and the Minister of Finance, because the Minister of Finance brings money in. What this pandemic has shown the world, and by the way, Ebola did the same thing at a smaller scale, is that when a pandemic happens, the consequences are broad across the economy. It's not just health that suffers, it's the economy that suffers. And so the suggestion that came out of this commission was that we should ask the IMF to consider investment in health infrastructure as a parameter of the nation's economic health. Because, as you know, this one pandemic has wiped out 10, 20, 30% of many large nations' GDP in one fell swoop. The cost of that is astronomical. And yet a small investment in health infrastructure could actually help or mitigate that. The IMF has not yet taken up that suggestion, but the cost to nations all over the world would suggest that that kind of assessment of a nation's infrastructure in providing loans or financial guarantees to nations would be very impactful, because then the Minister of Finance would consider this a high priority as opposed to an expense that may not be necessary. Agnes, you have a comment?
Actually, it's worse than what you try to say. You know that, for an example, there was a project to reinforce the capacity to do research with the World Bank, where Jim was there, at the condition that the government take a loan. And if you fulfill your commitment, the loan will become a grant. So we were ready in Rwanda to do it. You know who was against that? IMF. You are not allowed to take another loan. So not only they know what you say, because they are full of intelligent, great brain there, they have another agenda, and they are not there to help us. Just look, for the time being, every country supported by IMF never found its way out of poverty. It's not by chance.
Yeah.
Nobody make them accountable. So again, it's a matter of accountability. If IMF experts were accountable with their great recommendations, and they have to pay the price of bad recommendation, they will act differently. But now they can say anything, pull the country down. You remember the structural adjustment? I was just a young doctor and I wanted to work for a public sector. And I went in a country and they were not allowed to recruit me because they were not allowed to invest in human development. They had to invest in private sector, IMF. So there is a lot of change to do that impact things like the disease where we are all fighting now. There is also those international organizations that are not really focused on the most vulnerable development and human development.
We have a couple of questions from the audience, and perhaps we can address them. One question that came up: what should guide decision-making for those in the global north, privileged enough to receive the vaccine, when considering travel to those areas in the global south who have not had access to the vaccine? Should solidarity hold us back? That's a very complicated question.
Yes.
Well, I would say one thing, just scientifically, there's no evidence at this point that the vaccines prevent transmission. So the reality is that the vaccines can prevent the vaccinated person from having a symptomatic infection, but they do not necessarily prevent the vaccinated person from either harboring or carrying the virus or having a true asymptomatic infection. So in a sense, being vaccinated doesn't protect those around the vaccinated person, although they might protect the person himself or herself. Other comments from Paul or Agnes?
Well, I mean, it's almost a philosophical question. I mean, I would assume, although as you say, the evidence is lacking, that anything that makes a viral disease less deadly probably suppresses viral load and infectiousness at the same time. Obviously, there's questions of the nasopharynx and how this works, et cetera. But the real issue is probably, first of all, I also find it a complex and thoughtful question. I mean, the solidarity, should solidarity hold us back? That was the question. Well, I think solidarity usually propels us forward, and there are all kinds of solidarity. But I would just keep adding that word pragmatic to it, because right now, as we know from our experience wherever we are, including in the United States, people are in real need of pragmatic solidarity. their problems are material very often. Yes, they're also psychological, enormous isolation, substance abuse, depression, domestic abuse. But there's also problems with rent, with unemployment insurance, the long laundry list that I don't have to add here. And that's been very hard in some of these countries in Africa where there are very few cases. You know, the lockdowns, the social distancing, where they're being observed, and they were in Rwanda when I was there in August, it's still terribly hard on people who are used to being able to move around the country and across borders to make a living. So I would just say every time we use the word solidarity, throw that pragmatic word right on top. There are kids who are out of school. I mean, it's the same story. And I think, as Agnes said in opening this up, these events bring out the best in people, as well as some less flattering traits. And, you know, all of us have to do more to help each other, whether we're in proximity or far away. And I'm sorry to sound kumbaya-ish. I am kumbaya-ish.
And
Agnes,
also,
can you tell me if the borders of Rwanda are open or closed?
they are open, but you need to come with a negative test less than 4 days. Second, you need to isolate yourself during 5 days and get out with another test negative because of this unknown. And many of the, we have a control of the pandemic now, but we still have daily cases. We had something like 250 something deaths since the beginning. So compared to other countries, we could not complain. But as you have said, we don't have the medical equipment to let the pandemic spread. And also, even if it has an economic cost anyway, even when you control the pandemic, you cannot do differently than to control, just because we put human wellness as the major preoccupation of your Minister of Finance. You know, your Minister of Finance has just to manage the money that it's yours and mine. Huh? Don't give him more power than is a man on the job or a woman on the job. Huh? Is not a powerful, it's somehow we are creating the monster that some of them have become. So solidarity,
Is there
to come back to solidarity, in my point of view, countries that has the money to manage the pandemic and messed up is just because they have cultivated individualism, and solidarity has no big place in that the current culture and the current way of life. And this is also something that this pandemic has demonstrated.
I'm just wondering, are vaccine doses available in Rwanda now?
Very little, very, very little. We start vaccinating. The country is ready to vaccinate the entire country. When we say entire country, there is a list of people. First will be the frontline workers to allow them to work in security. That will decrease the fear to provide health and work with everybody. Second will be the elderly and also people in refugee camp, in prison, where there is a concentration that you cannot necessarily avoid because you don't have the infrastructure or the land or the opportunity. You see, we had cases in prison. Some prison has been really close, etc. And some prisoners brought in very, very nice hotel just for isolation, just to protect, you know? So there is a list of people who will be vaccinated that go with the science and the human development spirit.
So there's a question from the audience. Given the scarcity of Western vaccines, could you speak about the efficacy and potential for distribution in Africa of vaccines developed in Cuba, China, Russia, and possibly other nations?
Well, Tachi, I'm sure you'd have a lot to say on that as well, given your knowledge of
The
your greater
Russian
knowledge.
vaccine,
What's
the
that?
Russian vaccine, I just said that the vaccine developed in Russia and China are already on the African continent.
Yeah.
And what is funny is that people have saying, are you not afraid that they use that to get influence? Oh my goodness. I better be a little bit influenced and alive than a non-influenced dead body.
I was going to say something similar, although in much less colorful language. First of all, to the question, it would be a mistake to write off the potential of those vaccines. First of all, both, China, Russia, and India, in any case, have a very large vaccine industry and have put out good vaccines for many decades. So, if I had been in Russia at the time, which, I would have happily signed up for one of those vaccines. We do need to contemplate, again, and going back to the logistic questions, the cold chain and what the greatest requirements are. Obviously, an oral one-dose vaccine is what I say obviously, but imagine that's on the minds of many people, right? How do you go? And this is a standard trajectory for a vaccine, injectable at first, but that's going to be the goal, something that's easy to slip into an expanded program in vaccination and becomes routine. But I would definitely imagine there's going to be a very big role for the Russian. I'm not familiar yet with the Cuban vaccine, but again, they've been credible developers of vaccines, usually along with many partners that hadn't been developed in the United States or Europe. So we're all keeping our eye on this. As Agnes said, it's already a biosocial event, right? The vaccine from China and Russia is already on the continent, which I think will be a net good. We're all waiting for more information on the variants. I mean, the AstraZeneca vaccine seems to have been dealt a bit of a blow. Again, my conversations have been informal and with people like Tachi, but we're going to need a lot more vaccines going forward. I mean, a lot more different vaccines as well.
I think as far as these vaccines are concerned, really, it's a scientific question. Do the vaccines have the same efficacy or do they not? It looks like the Russian vaccine is a very good vaccine. The Chinese vaccine, the Sinovac vaccine, is nowhere near the efficacy of the other vaccines. And I don't know anything about the Cuban vaccine. But having said that, the real question is, just because a nation is poor, should they get an inferior vaccine? The answer is, of course not. And if you were living in Africa, would you rather have the Pfizer vaccine or the Moderna vaccine if it were available than an untested vaccine or a vaccine of lower efficacy? The answer is no. But in the current circumstance with a pandemic that is as widespread as it is, you'll take anything you can get if it has the science to support it. So
Tachi, let me tell you something. People vaccinated with the Chinese vaccine, there is no death and there is no need of respirator. This is also science, What do we miss in Africa? I can get a very bad flu if I'm not at risk of death, of dying, and if I'm not at risk to be on a respirator. So also something, last year for the flu vaccine, efficiency was 50%. What did CDC Atlanta say to the American? Vaccinate anyway because the best prevention is vaccine. It was 50%, the vaccine, the efficiency of the last flu vaccine. So science doesn't change because we change disease. So vaccinate with what you have.
I agree, but I think that all I'm saying is that just because you're poor, you shouldn't have necessarily
Agree.
to accept a vaccine that is inferior. If you
I,
have
I
no
agree.
choice, you take whatever vaccine you get.
Yeah.
I
We
will say
can't.
this much, supply from China will be very plentiful. Supply from Russia will not be plentiful. They have a very big supply issue even within their own country. So I think it's going to be an interesting um, evolution of the different solutions being distributed in Africa. But to date, there's none that demonstrates that it provides protection against the South African strain. And that is the strain that is spreading the fastest in sub-Saharan Africa right now. And that's a big challenge that we have to address. I'm afraid we're coming to the end of the hour. It's been very interesting and widespread discussion. Just to summarize some of the key points, I think a critical issue is right now that this is a problem in Africa, just as it is everywhere else in the world, that its presence in Africa has global implications, not just local implications, and that therefore there's a compelling need to address the pandemic in Africa as it is in any other part of the world. Availability of vaccines is a critical one, and that has to do with the pricing and the priority and the distribution infrastructure, a sense that the infrastructure is there if the vaccine's available. There's an issue of whether the cost is appropriate given the global nature of the problem. And that's a problem we're not going to solve, I'm afraid. I saw a headline article in the Wall Street Journal this morning that the executives of the firms that created the vaccines cashed $500 million worth of stock that are gains from the vaccine. And I have to tell you, it made me a little bit sick to read this. But this is a moral and ethical issue of equity that has to be addressed. I think the point that vaccines from other parts of the world are available is very important. And given no options, people will absolutely take them, should take them, and they will have efficacy against death, if not necessarily against symptomatic infection. But we have to remember that people should have just as much access to the best vaccines as anybody else, and that we shouldn't have to settle for something less than the best. And overall, I think that we are fortunate so far that the problem hasn't killed the number of Africans that we might have expected to die from this. But this is only the beginning of a pandemic that may last for well beyond the year, and maybe the worst is yet to come. So discussions and preparations that we're having now and hopefully elsewhere in the world will have impact on the global nature of this pandemic. So thank you very much, Agnes and Paul, for participating in this. I know the University of Michigan is deeply grateful for your participation. I'm personally grateful to be able to spend the time with you and to have this discussion. I'd love to have this over dinner sometime, as opposed to on Zoom from all corners of the world. Thank you very much.
It was great to be with you, Tachi and Paul.
Thank you.
Thank you
Thank you,
very much.
Brody, and thank all of you who set this up. Thanks, Tachi.
Thank you.
See you soon, Agnes.
See you soon.